It's wonderful to greet everyone who's joined this special webinar. I want to give a special greeting to all of you from the United Nations and UNITAR, the United Nations Institute for Training and Research, the Global Surgery Foundation, Operation Smile, and Stellenbosch University, who are all partnering together for this webinar, restarting non-emergent surgery in low and middle income countries. A very, very important topic, and we have a wonderful lineup of speakers today. And I would like to just turn it over to Kate Tylenko from Operation Smile, who is our special moderator today, and she will introduce our speakers and moderate the session. So thank you very much for joining us, and please participate through the chat line and question and answers as we go through, and Kate and I will try to answer some of those questions during the conversation. And there'll be opportunity for interaction a little bit later. So Kate, I'll turn it over to you. Thank you.
Thank you so much, Jeff. And first I want to thank Julia, Megan, Rachel, the speakers, and everyone who helped put this webinar together. So I'm Dr. Kate Tylenko. I'm a pediatrician and health workforce specialist. I'm the former head of the U.S. government's Global Health Workforce Project, and I've been helping Operation Smile with their global education and training strategy. Operation Smile for close to 40 years has been improving essential surgery systems in low and middle income countries through the lens of cleft surgery. And during the past 6 months of the COVID pandemic, Operation Smile has been working in its 30 partner countries to help strengthen hospital responses to COVID. But certainly now 6 months in, hospitals are getting used to the new normal. Hospitals are able to provide better levels of personal protective equipment, and have done their infection prevention and control training. And now they're looking at restarting the non-emergent surgery, which had been paused for 6 months. Because as people are looking at morbidity and mortality during COVID, there's increasing concern that morbidity and mortality from delayed surgery may start to exceed the morbidity and mortality of COVID. And both the American College of Surgeons and the UK Royal College of Surgeons have put out guidelines for restarting surgery in the time of COVID. Also, the University of Chicago has put out the medically necessary time-sensitive prioritization worksheet, which helps surgeons prioritize what surgeries they should do during COVID. However, all of these approaches have been designed in high-income countries. So how do surgeons in low and middle-income countries decide when to start surgery and what surgeries to prioritize? So those are some of the questions that we hope to answer today. And we're aware there's a lot of information out there on the internet. And so we hope that here today we can help you synthesize it, get your questions answered, and think about how you'd like to apply a lot of these ideas to your own hospital. So we have 4 speakers today, and each has about 10 to 15 minutes to present. And then, as Jeff mentioned, we'll have questions and answers afterwards. So with no further ado, I'll introduce our first speaker, who is Dr. Sanjay Nagral. So Dr. Nagral is a surgical gastroenterologist with a special interest in liver transplantation and ethics. And currently he's the director of the Department of Surgical Gastroenterology at Jaslock Hospital and the head of the Department of General Surgery at Bhopal Municipal Hospital, Mumbai. And he's been teacher and guide for multiple fellowship training programs and postgraduate surgical training programs. Dr. Nagral has over 110 publications in peer-reviewed journal articles and has published 4 textbook chapters. And he's a member of the Executive Council of the Declaration of Istanbul Custodian Group, a global group devoted to ethics around transplantation surgery. He's also the publisher and chair of the editorial board of the Indian Journal of Medical Ethics and the chairperson of the Indian Forum of Medical Ethics. And in addition to his academic work, Dr. Nagral writes and publishes widely, including in some of the major newspapers in India. So please, Dr. Nagral.
Thank you. So can you hear me?
Yes, we can hear you well.
Okay, great. So first of all, thank you, UNITAR. Thank you to all the organizations supporting this seminar for this opportunity. I think it's a matter of a special and unique privilege to be talking to surgeons in these unprecedented times, surgeons across the globe. And of course, amongst the many challenges that we face as healthcare workers, One of them is restarting surgical procedures. Of course, there are many logistic issues, but what I hope to do in my presentation is focus a little more on from an ethics lens, because that's an area of interest for me. And of course, when I say ethics, we will be, of course, taking a very broad, wider definition of ethics and not just a very narrow definition. So here's the plan that I hope to use for my presentation. Next slide, please. So one of the things that we must pause and look at before we jump into the discussion proper is why is elective surgery stopped during the COVID pandemic? And of course, it is about using resources for the COVID patients. We all know that. It's about infection to personnel, which is a big issue. And of course, we need to remember that COVID patients and even non-COVID patients have increased mortality and morbidity in the post-operative period. And we'll look at some of these issues in a little bit detail later. But what I wanted to immediately point out is the fact that this distinction between emergency, elective, essential, these are all terms which are relative. And whilst we need to have some definitions, but these could change from country to country, especially in LMICs, because we already have pre-existing delayed presentation. So what is elective in some countries can actually be essential in certain countries. Next slide, please. So here's a quick look at the background pre-existing challenges in LMICs. And many of you know this, so I'm not going to discuss all of them in detail. We wrote this piece for the BMJ a few years back with surgeons from across South Asia, and my talk is going to have a little bit of South Asian bias because that's where I work. And we actually looked at what was the biggest challenge to surgery in South Asia, and it was really the unmet need for surgery. So there is the pre-existing unmet need. Then, of course, there are dysfunctional health systems. There is a fair amount of stigmatization in our cultures around COVID. We also have a peculiar situation, especially in South Asia, of a parallel, dominant, but very unregulated private sector. And finally, of course, the ethical and oversight is pretty weak in this part of the world. Next slide. And here's Mumbai, here's my city. And Mumbai is a big city, 22 million at the last count. We have seen 1.2 million COVID cases. So it's been very much at the epicenter of the epidemic in India. Around 8,000 to 8,500 deaths till today, with probably an underestimate. But what really happened in Mumbai in the early months is the fact that hospitals emerged as hotspots, including both the hospitals I work, and there were closure of several hospitals. So surgical services actually stopped for some time in the city in a large number of hospitals. Then hospitals have been divided as COVID and non-COVID. There's been a lot of problems with transport. In fact, in the early days, we had a situation of patients dying in ambulances waiting for beds with lots of emergency problems. So we have two systems and two worlds in this part of the globe. And I'm just showing you this picture to explain that. So here's one hospital I work on top, which is a private sector specialty hospital. Next to that is the house of the richest man in India, which is a 60-storied building. So he lives with a family of 4 in that. So that's the kind of wealth you can have. And I crossed this bridge across the bay in Mumbai to work in this hospital here, which is one of the large public hospitals of Mumbai. And this is the population we serve in that hospital. 60% of Mumbai lives in slums. And that's a very specific challenge. And one of the peculiar things that is now emerging is that the private sector is keen to start surgery because it's revenue for them. Whereas the public sector has been completely overwhelmed by COVID, and therefore they are extremely reluctant to start surgical procedures. Next slide, please. Now, here are some factors which are unique to surgery in COVID. Again, most of you know this. We already discussed the post-operative problems. But COVID, of course, for a surgical team, there is a specific issue of the operation theater exposure, and many surgeries have a lot of aerosol generation. So there are specific safety issues. And there is already some emerging data from across the world. The famous COVID-Surge study, which is published recently in the Lancet, and that's a HIC study, really. It's high-income countries, I think 1 or 2 countries from LMICs, which showed 28% mortality in COVID patients. I've just put some data from Mumbai. One of them is up for publication, one of them is unpublished, which looked at what happened in some of the institutions here. And a big cancer hospital in Mumbai has operated 412 patients with no mortality, with only 6 of them were COVID positive. So there is a lot of variety of data that we're going to see from across the world, depending on which part of the world it comes from. Next slide, please. Now, what is essential surgery? I mean, it's a challenging term because it means many things to many people. But of course, you have a cancer, which obviously needs early surgical interventions. But you could have a necessity for essential surgery for pure symptoms. So pain, bleeding, abscesses, which need to be drained early, prostatic enlargements, which are huge, which cause urinary retention. So this is all very essential from the patient's viewpoint. Of course, a lot of surgery relieves disabilities, so you have fractures, and improved quality of life. And for our patients in LMICs, whether it's blindness due to cataract, whether it's reversal of stomas, they're all quality of life issues which actually need fairly urgent attention. And of course, there is this group of surgical diseases which needs interventions, because if you end up with a complication, then you're going to have a much worse time in terms of the treatment. I'm just now going to come to the next slide, please. So I'm going to come to the ethics lens. And I think the ethics lens is important because it gives you a global universal value of how we approach the problems of restarting surgical services. So public health ethics is clear about a certain principle, which is the equal moral worth of individuals and justice in a health emergency. Now, of course, on the ground, it operates in a very different way. But I think the ethics lens is important to all of us across countries as an overarching lens to approach some of the dilemmas that we're going to face. We must also keep in mind in LMICs, there is extreme vulnerability, the information asymmetry, and our countries can be very hierarchical. So there is discrimination already inbuilt in the system. And therefore, the ethics lens, which constantly reminds you of the need for justice to everybody, is extremely important. Next slide, please. So what are the ethical challenges? In my view, the first and the basic challenge, which I referred to, is the fact that there is denial of surgery. That by itself is a big ethics challenge. And we have had a lot of collateral damage in our country of patients dying, waiting for procedures like abdominal emergencies. Then, of course, the question of prioritization and rationing. Because of the resource limitations due to COVID, and there are various ways to prioritize. And again, these are all standard ways, many of you know this. But of course, we can use tricky areas like what is productive value of a citizen or an individual when you talk about long-term gain. Should age be the only criteria? And of course, we must keep in mind that in many LMICs, including my part of the world, gender is a very important issue. We also have the issue of the safety of the patient versus the safety of the staff. And here there is an ethical principle involved of reciprocity, which is that, of course, whilst there is a commitment to offer treatment, provide treatment, there's also a commitment to provide safety to the healthcare workers. Next slide, please. We come, of course, to the big question of informed consent. Now, how informed is informed consent is a debate even in normal times. In LMICs, there is a debate about how much to disclose, even in routine times. And the fact is that in LMICs, the extent of disclosure can vary from cultures to culture. There is, of course, a big role of the family in our part of the world. There have been the old barriers to informed consent, but we have now a new barrier, which is the barrier of communication in COVID times. So you have people wearing PPEs, masks. We have social distancing and isolation, and it's emerged as a huge problem in Mumbai because most hospitals do not allow family members now to be present in the perioperative period. And that's leading to huge trust problems and huge practical problems that patients are facing. Of course, what is recommended is the use of digital and audiovisual devices, but how much can these replace the actual face-to-face discussions and connect with family members is an open question. Next slide, please. And I think this is my last slide, which tries to look at the way forward for all of us as we approach this problem. One of the things is, of course, to incorporate universal ethical values and framework in the policy making and prioritization. I think that's a good overarching thing to keep in mind. We need leadership from professional organizations. And I must say this, that in our part of the world, unfortunately, organizations have currently focused on protection of the healthcare workers. But we need to be patient advocates because the collateral damage that our patients are undergoing is best known to us. We, of course, need to promote shared decision-making, and there need to be clinical ethics committees in institutions. Ethics committees in India largely deal with research ethics and do not really look at other issues. So I just leave you with this message of this figure here, which essentially says that we need to do this fine balance or tightrope walk between the need for essential surgery, on the other hand, the safety of the healthcare workers, and of course, the safety of the patient, given the cultural and socio-cultural background of LMICs. Thank you for your attention.
Wonderful. Thank you so much, Dr. Nagral. I especially love that last slide of yours showing that sort of three-way tension between the need for the surgery, the safety of the patient, and the safety of the healthcare worker. That was very helpful. So our next speaker is Dr. Catherine Chu. And Dr. Chu is a colorectal surgeon and professor of global surgery in the Department of Global Health at Stellenbosch University in South Africa. And she is currently the Vice President of Doctors Without Borders South Africa, and is on the board of directors of One to One Africa, a nonprofit organization that provides mentor mothers with HIV positive pregnant women. And previously, Dr. Chu worked for the University of Rwanda with the Human Resources for Health program to train Rwandan surgeons. Dr. Chu's research focuses on equitable access to essential surgery for Africa, with a particular focus on strengthening surgical capacity at district hospitals. And Dr. Chu is she's also conducted research on improving quality of care for humanitarian surgical delivery. And we're especially excited to have Dr. Chu here because South Africa has the largest COVID outbreak in sub-Saharan Africa. And very similar to India, the South African system has both world-class private hospitals, but also struggling public hospitals. So please, Dr. Chu.
Thank you very much, Kate. Good afternoon and good morning to all of you on the call. And I'm very pleased to be a part of this webinar. And I would just like to thank UNITAR, the Global Surgery Foundation, and Operation Smile for asking me to participate. I think the lighting is not great. I think my talk kind of segues nicely from Dr. Nagral's, because a lot of the things he mentioned that were happening in South Asia are also happening here in Africa. And so, just to highlight a few things, but they are quite similar, is that pre-COVID, surgical access is extremely limited in sub-Saharan Africa. Long waiting lists already existed. Access, especially for rural populations, was really quite poor. And as Kate mentioned, there's a large inequity in sub-Saharan Africa. And since March, when the pandemic hit sub-Saharan Africa, and specifically South Africa, there's been a drastic reduction in elective operations. And by one estimate done by COVID Surge Collaborative, 28 million operations have been canceled worldwide and need to be done in the next sort of 12 weeks, or 28 million operations secondary to 12 weeks of the pandemic will occur. And that's a huge number. And then just a little bit of background here in South Africa. So we have over 40% of all the cases in sub-Saharan Africa. At the moment, I think these statistics were from a few days ago, we are almost up to 500,000 cases. We have about 12,000 new cases a day. Interestingly, our mortality so far is quite low, only 2%. Next slide. So just wanted to first mention that in March in South Africa, and I think several countries in sub-Saharan Africa followed suit, that we actually had a national lockdown when we only had 20 cases. And this was to prepare for the pandemic. You know, the pandemic came to high-income countries like the US, European countries, and we saw their health systems overwhelmed. But we here in sub-Saharan Africa didn't know what would happen here. And so the national government took a very strong policy to have a national lockdown, which essentially disallowed all movement within the country that was non-essential. And that included a real discouragement to attend healthcare facilities except for emergencies. And you know, there's obviously a large interpretation, as Dr. Negral says, of what is an emergency and what are sort of urgent health conditions. But here in South Africa, we saw a huge decrease in the number of outpatient visits, emergency room visits for all kinds of conditions. And then there has been a real question of, you know, what's happened to all the stroke patients? What's happened to all the heart attacks? We did our own survey here in South Africa. We did a national survey of surgeons who worked in 85 different hospitals, which we think represented about 20% of hospitals nationwide. And it showed what you probably would expect. 99% of elective operations and outpatient visits were canceled or reduced. And a third of hospitals had at least one operating room repurposed as an ICU ventilated bed, which I found was very interesting. So in the beginning of our pandemic, this was all done in preparation for COVID cases, but none had actually occurred. Then later in May and June, as the pandemic truly hit South Africa, elective cases remained unoperated on because then our hospitals became overwhelmed. And I think that the question for this webinar, the title was Re-escalation of elective surgery, restarting elective operations. But I would like to actually maybe rephrase that to saying, how do we reprioritize, or how do we prioritize the surgical cases that we're going to do now? Because as Dr. Negral says, in our part of the world, in LMICs, there are really no truly elective operations in the public sector in particular. And so it's just shades of gray of how urgent the operation is. Yes, there's some ones that are very obvious, like life-threatening or limb-threatening procedures that need to be done. But otherwise, you know, many other cases need to be done urgently, meaning ideally before they leave the hospital, but maybe not tomorrow. And so I think that that's now where we're at in South Africa, is how do we factor in what's happening with COVID? How do we factor in with what our hospital resources are in order to decide which operation should proceed? Because there's no doubt where we are not going to go back up to 100% of where we were in terms of surgical volume for a long time. And in the private and the public sectors are varying in that, but even in the private sector, they still are not able to go up to 100%. So then what are the factors that we need to consider? And Kate mentioned numerous guidelines that have been published by high-income countries around this. And how does that relate for us here in sub-Saharan Africa or in LMICs? Well, first of all, some of them do apply to us. So local COVID factors. Are your daily cases still increasing? You know, most people would say if they're still increasing, you probably should not even consider restarting elective surgery because you don't know how high that curve is going to go. If they're plateauing or if they're decreasing, then I think there can be some consideration. What about your hospital capacity? How many beds are being used by COVID cases? If more than 50% of your hospital beds are being operated by COVID cases, and there just really aren't extra beds for surgical patients, again, probably a consideration not to restart. Shortage of surgical staff. So here in the Western Cape, we have some hospitals where, or in our province, where over 2,000 staff are out sick with COVID. So that is, you know, a huge portion of our surgical workforce. So then we're not really able to restart. And then also, as Dr. Negral mentioned, the safety of the healthcare workers. If there's not appropriate PPE for surgical staff, especially for the anesthesiologists, then one really shouldn't reconsider starting. So in the US, surgeons wear PAPRs, so this positive ventilation. It almost looks like a spacesuit that the orthopedic surgeons used to wear for joint replacements. You know, we don't have any of that here in sub-Saharan Africa. So what is safe for our part of the world? And then the last point I would really like to discuss a bit is the ability to test preoperative patients for COVID. So that varies between countries. Here in South Africa, in the public sector, only until recently, the turnaround time for testing was 10 days. And so even if we were able to test, we couldn't do much with the information on the emergency patients. For elective cases, it still wasn't practical, because if you tested your patient, where were you going to put them for 10 days while you were waiting to get the result? Because if you let them go home, they might become positive again in those 10 days. We don't know. Now the turnaround time is faster. And, you know, in South Africa, we do not have national guidelines on how to prioritize restarting surgery. But this is what I'm on a task force now to develop that, because there's a real need to decide what factors do we need to consider before restarting. And COVID testing, I think, is a really essential part of that, because, as Dr. Nagral mentioned, the COVID Collaborative published in The Lancet that almost a quarter of patients who underwent operations who were COVID positive, whether they had symptoms or not, ended up dying. And half of those patients had pulmonary complications. That's a huge number. Now, again, we don't know if that's going to play out as there are more numbers of patients. And maybe it was because they were in hospitals that didn't separate the COVID patients from the non-COVID patients. And so perhaps there are confounding factors on why that mortality was so high. But given that, what do we advise patients? Dr. Nagral mentioned the ethics of informed consent. You know, if a patient is coming in for a semi-elective procedure like a hip replacement, would they still want it if we told them they had a 1 in 4 chance of dying at this point? Maybe not. You can go to the next slide. So, you know, again, the other factors about prioritization or escalation is who decides. So some hospitals have multidisciplinary hospital committees where every single operative case goes before the committee, and the whole committee decides whether that is an appropriate case or not. In many hospitals, it's the surgeon's choice. So he or she gets to decide for the patient. But in a hospital where there are multiple surgeons from different disciplines and there's limited operating time now, if you've got 5 surgeons all saying that their patients need to go, who now decides? And as Dr. Nagral mentioned, here in Sub-Saharan Africa, it's the same as in India. We have large backlogs already. So every case now is urgent. So you can go to the next slide. So then who does decide? And Kate brought up this scoring system that was published by American surgeons. But I would like to go over this because here in South Africa, we are revising this scoring system for our own context. And I couldn't put it up because we haven't validated it quite yet. But the principle is the same. So this is called the MENS score, or medically necessary time-sensitive procedures. And essentially, it's a scoring system to rank patients against one another to try and decide, given your current resources, should you proceed or not. So if you look at the scale here, they've got sort of green on the left, okay to proceed, and then on the right-hand side, procedure not justified in red. And purposely, they actually don't tell you where the score numbers are, where you should draw those lines. And those lines are changeable depending on your hospital's current capacity. So, you know, for us, we've got district hospitals that might have 1 surgical provider and 1 theater, and we've got huge academic hospitals with 30 operating rooms and 20 to 30 surgeons. And so we want a scoring system that can actually be used in all these places, depending. And I just want to spend a few minutes going over what it's about. Essentially, the MENS scoring system takes into consideration the procedural factors, the disease factors, and the patient factors. Next slide, please. And again, I think that this scoring system needs to be redone for our context because some of these points are not so relevant, and I'm happy to share that once we get our own modified MENS out. But I think the points are still valid. So the procedural factors is how long is the patient going to spend in the operating room. So the longer the operation, you know, the more likely you should, the more consideration that you should defer the patient. So operating time, is it going to take 5 hours? It's going to take 30 minutes. The length of stay, so again, hospital beds is really critical at this time. If it's an outpatient procedure, perhaps more likely consider it versus a large abdominal operation that might make the patient stay for 7 days. ICU needs, again, if the patient's likely to need ICU, probably should reconsider. Blood loss, surgeon team size, you know, if surgeons are at a real shortage or staff are at a real shortage and you need 3 surgeons to do the operation, perhaps maybe you should reconsider. Intubation is a big one. Dr. Nagral brought up the risk to healthcare workers with the aerosolization, if you can do the operation under local or regional. maybe a bit better. And then they mentioned surgical site. Next slide. So the next one is disease factors, and I think this is the most difficult one, and this causes the most arguments between surgeons. So essentially it's, is there a non-operative treatment for your patient's disease? Probably not, otherwise you wouldn't be arguing with their hospital committee about whether you should proceed. But if you deferred for 2 weeks, how much worse would the condition get? So symptomatic cancers is often brought up. You know, can you delay it for 2 weeks? Can you delay it for 6 weeks? What would happen to the patient? And so, you know, this scoring system is quite subjective in some way because it says, you know, the patient's going to get worse, significantly worse, no worse. And what's the data for that? So you have different surgeons trying to argue differently, but this again tries to make it somewhat objective. It's kind of like before we used to use, you know, does the patient need to go to theater in the next 6 hours, in the next 24 hours, in the next few days? And that used to be a triage system. So this is sort of like that. Next slide. And this last slide is the patient factors. So, you know, because the risk of dying, at least according to the Lancet study, is 1 out of 4 right now, it's really important to know what are the patient's underlying risk factors for mortality, morbidity anyway. So some of those are the ones that we always considered: age, underlying lung disease, cardiac disease, diabetes seems to be a big factor now, and COVID risk, being immunocompromised. And here on this scale, they said exposure to known COVID positive person in the last 14 days. I would argue now that that should not be on the scale because we should be pre-op testing everybody. So perhaps to take that off. But essentially, you know, this is my last slide, is just to say that it is a very complex decision-making process. And then, you know, there are special considerations. For example, pediatric patients. You know, right now the data seems to be that children don't seem to spread COVID very much. And children seem to either have mild or asymptomatic disease. So for children that need operations, do they need to undergo the same testing and the same kind of rules as adults? I think that's something else to consider, because for Operation Smile, I think you do have a large pediatric population, and in Sub-Saharan Africa, we have a large pediatric population to consider. So I'll stop there. Thank you very much.
Great. Thanks so much, Dr. Chu. And I think it was especially helpful the way you went through the MENTs. That was really very helpful to understand that in more depth. So our next speaker is Dr. Hatim Droussi. And Dr. Droussi is a plastic surgeon from Marrakesh, Morocco, and he specializes in aesthetics, burns, and congenital malformations. Dr. Droussi is Deputy Secretary General of the Moroccan Society for Aesthetic and Plastic Surgeons. And Dr. Droussi has been a valued Operation Smile volunteer since 2008 and has operated in over 20 surgical missions, and he's led a number of those missions. And so Dr. Droussi will give us the perspective from a middle-income country, actually a country of Morocco, which has handled its first outbreak very well, but is now starting to see a surge with the opening of the economy. Dr. Droussi, you might need to unmute yourself.
Is that okay for you?
Yes, yes.
Great. So thank you, everyone. Hello, everyone, and good afternoon. Thank you, Operation Smile and UNITAR for the invitation. It's a real pleasure for me to be one of those great panelists to discuss this really important topics on how to restart safely the non-emergent surgeries in LMICs. I will say during COVID-19 because it's not over yet, unfortunately, and not post-COVID-19. So next one, please. So I will go through those generalities really quick. So this is a worldwide infection. This condition has led to a numerous postponation and cancellation, unfortunately. So the resources were redirected through for pandemic preparedness and response. For the example of Morocco, we had an early and very effective response since the first case declared in the 2 March. So the total lockdown for the country was 18 days after. Actually, we are partially unlocked depending on cities and regions. So immediately the national government has statute that private and public hospital will have non-emergent and non-urgent medical and surgical operation must be postponed. They promote the teleconsultation, the enhancement of hygienic measurements in clinics and hospitals, as the WHO recommends. For the public hospitals, we get the separation between, like, we have special pathway, as Kate said, special pathway for non-COVID and COVID. So we have a whole hospital for COVID and the whole hospital for non-COVID patients. So we have a low risk of cross-contaminations. Next one, please. This has led to accelerate the establishment of this policy to restart work in private, because we have seen like big numbers of non-COVID pathologies, complications. For Morocco, so the Moroccan Medical Council has said that all scientific societies must make their guidelines specific to their practice. So for us, we have 2 plastic surgery societies in Morocco, and they had made their own guidelines inspired from those of other countries in Europe and USA, and applied or adapt to our reality. The actual situation in Morocco up to the 26th of July was about more than 1,900 cases and 16,000 recovered. Deaths were 305, and the R0, the multiplication factor, was increased in last few days to reach 1.12. We have no statistic about impact on non-COVID pathologies care, but we see in our practice that we have a high rate of complications and deaths due to non-COVID pathologies. Next one, please. So the recommendation that we have put for both societies are segregates into organization in the office and for surgery in clinics. So for the office, we have promoted the online consultations, reservation only, no direct reservations, especially by phone or email. The temperature must be taken at home before coming. If any symptoms occurs, the patient will not be able to come. If there is a contact within the 14 days before the time of consultation, no consultation will happen. So enough empty time between 2 appointments to ensure the contamination of the office. All the personnel, all the workers in the office must put mask and use alcoholic gel. Take the temperature of the patients when he arrived. Keep 1 meter at least distanciation in the waiting room. Keep an airflow, open windows in the office, and regular decontamination after each visit and each patient. For the filling of the information, we have limited the contacts with the receptionist if the patients fill himself all the information. And during the consultations, he keep his mask for body consultation, face shield and mask for surgeon and for facial exam, and decontamination of area and tools after each patient. During local procedures, of course, face shield and mask for nurses and doctors. So for surgical patients, we have seen that surgeries can enhance, a lot of studies shows that can enhance the severity of asymptomatic patients or symptoms in a mild condition that can lead to a high rate of mortality. So the goals of this of selecting patients for surgery is to limit the spread of the virus first, avoid exacerbation of asymptomatic patients, and avoid getting infected in the perioperative period. So what we have set as measures is that, unfortunately, we don't have a free access to PCR tests in Morocco. So the one who gets this PCR test is only the person who gets signs of infection or the contact subjects. We have conducted until now about 2 million tests until the 27th of this July. And so we decided to establish a list of exams that must be done before surgeries. So first, anamnesis on selection patients. So no patients was accepted if they were negatively tested in less than 1 month, or if they have contact during the last 14 days with a positive case. For the lab exams, we do CBC, prothrombin time, kidney exploration, blood ferritin, and D-dimer, as some studies show that they are correlated to the high risk of complication in COVID. We have done, since we don't have PCR accessible, we ask the patients to do a thoracic CT scan 48 hours before surgery, because of the high specificity for positive asymptomatic case, like the ground glass opacification that we can see. And we will do that, waiting for PCR and immunologic tests to be set in Morocco. So next one, please. For anesthesia, the factors that Dr. Chu said are discussed like between the team, surgeon and anesthesiologist. So for the type and the balance benefits risk, so the anesthesiologist and the surgery team can do their appreciation and the statute that this patient could have surgery or not. Those are some considerations when admitting the patient. So hygienic discussed below must be applied in the clinic with a special pathway, preparing the room for mask and shoe cover for the patient, marking the patient with the surgeon only if possible in the room, and the transportation to the OR must be like a special way for a special way to drive the patients to the OR. For the surgery, we're working around, the working around must be limited for the teamwork only. The anesthesia and intubation with plastic cover to isolate the intubation zone. No complex surgery and no combined ones or surgery more than 4 hours. For body surgery, keep the plastic cover over the intubation zone. And for face surgery, cover nose and mouth with the Tegaderm with the plastic cover. Keep instruments inside the room in a plastic box. For the first decontamination inside the room, then to the sterilization zone, and keep enough time between procedures to ensure decontamination of the OR. Recovery room with more space between beds and 1 nurse for each patient if possible. Next one. For the post-operatory time, we recommend no more than 1 overnight. Note that private practice are out of COVID circuits in Morocco, so less chance to get infected or cross-contamination. No visits of family are allowed, and no administrative work to do for the patients. All I have done with our assistants, so they will know, the patient will not have to go to the administration to do some work. And the post-op dressing is recommended to be done at home, but a qualified nurse that we design for them. That will be all for me. Thank you.
Wonderful, thank you so much. I love the practical level of your advice around running a surgical clinic in the time of COVID, and then that last part about the surgeries and the spacing of the beds and the assignment of 1 nurse and doing wound care at home rather than having people come in. Very practical and very helpful. Thank you so much. So our next speaker is Mr. Ernest Gay, and Mr. Gay is Operations Smile Senior Advisor for Global Business Operations. And he brings 20 years of field-based experience working with nonprofits in sub-Saharan Africa. And Mr. Gay brings extensive expertise in designing, implementing, and managing complex and diverse teams. And Mr. Gay is a proud recipient of the Clinton Global Health Initiative Award for Outstanding Leadership and Management of Africare's response to the Liberian Ebola epidemic. Ernest also supported the Liberian Ministry of Health and other partners to rebuild the Liberian health system post-war, and was a particular champion of decentralization of that system. Mr. Gay holds a master's in equity studies from the University College Dublin, Ireland, and he remains active in his home country of Liberia through serving on multiple nonprofit boards, and he was appointed by the president of Liberia as a board member of the Bomi Community College in Liberia. And so we especially asked Ernest Gay to speak, to give us the perspective of what it was like to reopen services, health system services, during and after the Ebola epidemic, particularly from the point of view of how you organize services, but also how you communicate to the public. Because when you think about it, for 6 months, we've been telling people, stay away from hospitals, stay away from health facilities, don't come in. And now we're going to start to say, come back in, it's safe, it's all right. So how do we communicate with the community to make sure that they believe us and that they return to take advantage of the services? So please, Ernest.
Thanks, Kate. I'm really glad to be a part of this panel and to share the same platform with such great panelists. I also want to commend you and the UpSmile and UNITAR and the Global Surgery Foundation for organizing this forum. One of the things about speaking last on a topic is that the previous speakers may have already touched on all of your talking points, and so sometimes it's difficult to get in because it seems as though you're repeating. But in our particular case, I wouldn't go back to discuss some of the things that they have shared already, because I really do think that there are a lot of similarities, when it comes to responding to infectious diseases and the impact that they do have on health systems. And Liberia was a classical example, a country coming out of a devastating civil war. It impacted every fabric of society. But through it all, we had the support of the government and international development partners. And I just want to draw a parallel here and share some basic thoughts. One, I think, and Dr. Chu highlighted this, that is a critical challenge for a lot of low-income countries, particularly in sub-Saharan Africa, where surgery is almost seen as a luxury, simply because our health systems are not capacitated to deal with the surgical burdens. And therefore, we have someone coming from Liberia where some major surgeries had to be referred to either South Africa, Ghana, Kenya, or India. Now, these are countries that are already dealing with the burden of COVID itself. And that means that people who may be queuing in for surgery may not have access and cannot travel, to get the needed surgeries that they have. But I wanted to share that restarting surgery or restarting health services, one of the critical pieces, and I think what is core, is how do you rebuild the trust and confidence in the health system itself? Because the virus or the disease itself puts undue pressure. So Kate, and you and I talk about this, when you start off, the messaging and the communication you put out is, one, in the case of Ebola, we told patients, come to the facility. In COVID, we're saying, please stay at home. So there are two different messages, relevant, based on the context and based on the need. But it also sends a message out there that, well, the system is not strong enough, is not prepared. And then what happens? People often turn to alternative healthcare sources, and most of the times, those healthcare providers or those alternative healthcare providers are not equipped medically to deal with the situation that is on hand. So I think for me, that is the basics. How do we really try to restore and regain the trust and confidence of the health system? And then I will put it into two categories. One is the service providers. So the healthcare workers, frontline healthcare workers, all of those that are involved with ensuring that the services are provided. And then two, those who are actually receiving the services. Now, how do we assure the confidence and trust of the service providers? In Ebola, I think one of the things that we did was we really went back and review our infection prevention and control protocols and try to really reinforce compliance of those protocols. We did a lot of trainings of frontline healthcare workers on the protocols, and then went to the next level of remodeling the infrastructure. The doctors on this panel all talk about workflow, triaging, and even looking at the infrastructure itself. ICU, there are some hospitals that have limited ICUs, let alone ICUs that are specifically built for dealing with cases that are suspected of, an infectious disease. So I think that was another critical part of what we had to put into place. But I'm also aware that the response can be complex and requires significant funding to really roll out. And so, we did the protocol. We also went in and had to relook at the surgical procedure and guidelines checklist. And I know the World Health Organization has that as well. And I would advise, recommend that, people look at that as well. If you don't have one, you can modify it to your own context as well. But those were some of the things that we had to put into place. Beyond the infrastructure, we needed to ensure that we had appropriate testing and diagnosis capabilities, at all of the facilities that we were reopening or asking people to start to go back to get the services. I think these are really critical for healthcare workers, because then they feel safe, as Dr. Negral mentioned. You have to ensure that the healthcare workers or the service providers feel safe to provide the services, and also reassure those who are coming in to receive these services that they will not get infected when they walk into these health facilities as well. We had to invest in our quality assurance and quality improvement measures, and just overall supportive supervision to ensure compliance and adherence to some of these critical protocols and guidelines that we have instituted. So that was something that we did to reassure and restore the confidence and trust in the health system from a service provider standpoint. And I think that the last piece that I want to share on is the existence or the provision of medical supplies. That is critical. I mean, we've seen it here, the epidemic, the COVID-19 pandemic, the pressure that it plays on the provision of supplies, PPE and what have you. Obviously, when you institute your IPC protocol, you want to make sure that healthcare workers or service providers do have what it takes for them to really comply and adhere to the protocols and the guidelines. And normally, I would say, because a lot of these supplies are in demand, they're very costly. And so one of the things that we did, and again, this is just a recommendation, was to ensure that we had a buffer stock of supplies for a period of time. We have three months of supplies. Now you can go to 6 months depending on how much funding you have available to provide these supplies. But between 3 to 6 months gives you an ample time to really restart and rebuild that trust and confidence for healthcare workers to continue to go back to the facility and provide services. I think that the second track of that is more with those who are seeking services at the health facilities. We had to ensure that we engage communities. And I think, Kit, as you mentioned earlier, is around the messaging. What kind of messages do we now carve and how we send those messages out? So we had to go back and invest in community surveillance. We had to go back and engage the community structures, local authorities. It did take a lot of negotiation and conversation with the communities to really reassure them that, yes, this Ebola came in, it had a devastating impact on our health system, but we've been able to now, get back on track. We want to encourage you to come to the facilities. When you come to the facilities, here are the things that you're going to see. You're going to see a change in the way you were ushered into the facility, and you're going to see a difference in how healthcare workers are dressed. Don't be afraid of the way you see them, and don't get upset if it's going to take some time, a longer time compared to the time that you initially took when you went to the health facility. And I think that is really a critical piece of it, because once the communities understood that, then they started to gradually build confidence and trust in the health system to go back and seek care and services at those health facilities. So I think just coming out of Ebola, I just wanted to share some of those key lessons with this panel, and I'll be happy to respond to any specific questions that others may have. Thank you.
Great. Well, thank you so much. That was very helpful. I especially appreciated what you said about having to build trust again. Also that in many countries, if people can't go to the standard medical system, they'll go to alternative medical systems to seek care, and you might need to sort of unwind some of that. I do like the ideas of the managing of expectations. The health workers will look different, or the waiting line will be different, or the waiting room will be different, and managing those expectations and being transparent and communicating of it is very important. Well, thank you. That concludes all of our speakers. So we'll now enter the Q&A and discussion period. And so we've had a couple of questions come in already, but please type in any additional questions that you have. So the first I'd like to start with is a question for Dr. Chu or any of the other panelists on the MENT scoring system, and if you can give a little bit more context of it and how it's developed and used.
Sure, I can start to address that. So, I mean, the MENT scoring system, which again is to try to prioritize which procedures within a hospital system should be going before the other ones, was developed by a group of US surgeons. And, the scoring system and the point system that they created was pretty much just validated with their own context. And I think that the main question and concern is for our setting in LMICs, is that still valid and useful? However, for sure, some kind of system, I think, some kind of framework or scoring system could be really helpful in our context. I just think that we need to adapt it more and to simplify it a bit for our own context. But I think that all the points about, you know, how much time, the procedure, how much time is spent in theater, what is the risk to the rest of the staff, is there going to be need for ICU, how long are they going to stay in the hospital? That's quite an important factor. The specific disease, you know, if there's a way to objectively state, by not doing this procedure, delaying it for 2 weeks, is it going to make a big difference? Because it might, your pandemic may have changed in those few weeks. So can you delay? And then the last point, you know, is the patient's own comorbidities and obviously risk of exposure to COVID. So I think that in many hospitals, preoperative testing isn't available, or the turnaround time is so slow. So then how do we triage those patients? How do we assess their risk? So, you know, then I think if they've, certainly if they're symptomatic, that would be one thing. And I don't think that, and many of us are in the position like Dr. Drosy to get thoracic CT scans on all of their preoperative patients as an alternative. I thought that was actually quite interesting that that was available more than the testing. But you know, have they been contacted with other patients that have, other folks that have had symptoms? And I think that that will end up being the sort of triage system or evaluation of their COVID risk. But again, I think that many of us are in situations where then how do you isolate that person for a certain number of days before their operation? And I think there was a question in the chat that I'd also address, is that for emergency procedures that aren't life-threatening or limb-threatening in the next few hours, you know, then is it ethical, or should we be then preoperative testing all those, especially if you've got a turnaround time of a day or two? So an appendicitis, for example, perhaps can wait a day or two if you do have that testing. And I think those are all the unknowns, but I think that guidelines are needed, because I think that many hospitals are not allowing surgeons to do this preoperative testing, but many surgeons are asking for it, you know, to assess their own risk to the healthcare workers as well as to the patients. And I think that's something, as this pandemic progresses, there needs to be guidelines about.
Thank you. And it, you know, it actually also brings up the issue that potentially you can do pooled testing of some of the patients, like testing 5 at a time, which might enable you to test more people. Another question that I had was about governments or health systems helping hospitals economically regarding surgery, because we know in the US and a lot of private systems around the world, surgery is one of the big money makers for the hospital and subsidizes the rest of the hospital. So have any of you seen, you know, and so I think there's the concern that there might be a rush to return to surgery in order to get that income stream going. And have any of your countries addressed that issue?
I can speak for in South Africa. The private sector, I think, has really, I think Dr. Negral also mentioned it, because they depend a lot on the income of operations, but oftentimes it's also individual surgeons. So here surgeons don't work for the hospital, they work for themselves, but they themselves, their own practices are suffering, as are the anesthesiologists. But some of our health insurance companies here, we call them medical aids, there's been a negotiation with them that they're actually going to pay some of the healthcare providers, not just surgeons and anesthesiologists, but general practitioners as well, that have had a real reduction in their income. Some of a proportion of what they earned the year before is just a way to cover their livelihoods and their overheads, because the medical aids or the health insurance companies haven't had to pay out as much claims this year because people aren't seeking care. And so they've had already budgeted for that. And so that's an interesting sort of question, and, you know, raises, I think, other ethical issues about being paid for services that you didn't render. But again, these are extraordinary times.
Absolutely.
So if I may just add, the situation in India is that a lot of the public hospitals have taken the overwhelming load of the COVID cases and are unable to start surgery, are not keen to start surgery. So a lot of patients are being actually pushed to the private sector for early surgery, essential surgery. And that's a problem, because many of them cannot actually afford the costs. Incidentally, what the government has also done is to cap costs in private hospitals, because COVID patients in private hospitals were being given huge bills. So there was a big uproar. So it's a very strange situation right now for ordinary people, because they're being pushed to the private sector. and the private sector costs have been capped, and the private sector is not happy about it. So we don't know how it's going to go.
Interesting. Now, that's interesting to hear. Great. And another question that we received is that of having two pathways for surgical patients and all the equipment involved, whether it's the ventilators or the rooms and the beds. If people could comment on, you know, how do you do that if you have limited supplies, or if you don't have viral filters, or have a limited number of viral filters for your ventilators?
If I can speak for us, we haven't met this situation before because we don't have this huge number of cases like other countries have. So we still have like situation under control. The hospitals their capacities can manage the numbers of patients. In private practice, all private practice are doing only like a non-COVID patients. So in some public hospitals are like COVID hospitals and non-COVID hospitals. So there is no cross-contaminations between, no risk of cross-contaminations. And for supplies, we, thanks God, we never faced the run out of supplies until now. And we hope not to face it in the future.
Great, thank you so much. Another question that we've received is if some of you could unpack a little bit more, give a little bit more context to the study that showed that 1 in 4 patients, COVID patients, died after a surgery.
Yeah, so, you know, if I can just come in on that. So the COVID surge study is what you're referring to, largely from, I think, Europe and North America, if I'm not mistaken. I think one needs to look at it a little in detail. Number one, these were all COVID positive patients. I think a lot of them were fairly major surgeries and a very elderly population with comorbidities.
Exactly.
That don't know whether that's going to reflect in the rest of the world. I showed you some data from India. So whether that should be taken as the benchmark figure, I'm not sure. I think it depends on your patient population and the type of surgery. But of course, we need to keep in mind that there is a post-op mortality. If I can just respond to the COVID pathway question. So, you know, we've done that, but increasingly we are realizing that patients who are into the non-COVID hospitals or non-COVID wards turn out to be COVID positive. And there's a question which demands an answer, which is whether we should begin to approach this with some kind of universal precautions that we adopted for HIV, where, you know, we just assume everybody's COVID positive and get on with the job. I don't know what others feel about this.
Actually, I agree with you. I think in certain settings where you can't get timely testing, you do have to just consider that everybody's COVID and COVID positive and treat them that way, both for their safety, but I think even more so for the safety of the healthcare workers working with them. We had a lot of debates over that in the US with some health facilities wanting healthcare workers in outpatient clinics to not wear any masks at all or just wear a cloth mask, and people, of course, wanted the highest level of protection and wanted the N95 masks. So it certainly did kick off a big debate in the U.S. And we have another question, someone asking, do you think that the disability adjusted life year could be used as another tool for prioritizing for surgeries in the face of limited resources?
I mean, I think that's a great question, but I think that kind of question more addresses a little bit of, you know, the surgical backlog or how important the surgery is in order to improve life expectancy or life productivity. And I think Dr. Nagral kind of brought that up in terms of like the operation and then the return to functional ability. I do think that is a little bit of a slippery slope, however, because it then, instead of judging each person and their health condition versus that individual risk, you know, then you're kind of putting a value on that person and their condition and how much it's going to improve them. But I think it's a valid point because, in a sense, the scoring system, the MENTS, is about triage and it is about prioritization. And if you do have limited resources, there are many factors that go into it. So I think it's something to consider. But I think the one thing about the DALYs that's difficult is that the disability adjusted life years for surgical conditions has not really been well defined. So I think there are only a few conditions and procedures, cleft lip, cleft palate being one of them, and cataract operations being another. But for many of the other conditions, there isn't really a DALYs right now. And so I think that could also make it challenging to use that.
Thank you so much. And Jeff, did you have any questions for the group? Okay. So, other questions that we had was if people could comment more on pediatric patients. I think Dr. Chu, you mentioned that a little bit, but if anyone else wanted to comment on any special considerations for pediatric patients. And for example, are parents being allowed into the hospital, and what areas are they being allowed in, or for certain age groups?
Yeah, for me, I keep doing like cleft surgery for patients in my practice. So one parents are allowed with the child, like it's the mother. Generally, she is allowed to stay with the child during the one overnight of hospitalization, and I try to discharge them if I can by the same day. So for me, this is the only way, the only situation that one parents or members of the family can go. For my aesthetic surgery, regular surgery, no person is allowed and no visits are allowed.
Okay, thank you. Did anyone else want to comment on that? Okay, the next question is, given the huge backlog, do you plan on sharing the findings with your respective government public health officials and suggest a more nuanced approach to future pandemics? Like how will the lessons learned prepare us for continuing surgery during the next pandemic?
I think for me, that COVID has really highlighted the fact that surgery was already a public good that wasn't really valued, and the access to was quite poor. And the pandemic has exacerbated that. So I think in some way, we can turn this. I mean, they say, don't ever waste a good crisis. So I think that we should turn this around in surgical care to try to lobby for better access from the get-go, because I think that we're now in this situation because we had such a big backlog to start with, and now we were forced to reduce even more. And the other argument or strengthening is for anesthetic skills and critical care services. I think that they've sort of always been left out of the discussion about improving surgical care, but now with COVID patients, their skills have been highlighted, and I think that's something also to champion.
Yeah, that's a very good. Sorry, go on.
All right. So, I just want to reiterate one point which Catherine mentioned, which is that what COVID has done is actually highlighted many of the dysfunctionalities of our systems. In Mumbai city, for example, there's huge public discussion on how we neglected public hospitals over the years, and we allowed a huge private sector to grow, which is its own priorities. And I think there's been a lot of rethinking now. And in that rethinking, what is probably, I hope it happens, is the public healthcare system will get more funding and may get strengthened. So that's, you can say, a good fallout of the epidemic, if at all.
That's a good point. I agree with you. I see several comments here of people in a number of different countries saying they don't yet have the PPE they need to restart surgery. So that's, of course, disappointing to hear. And then there's a question saying, in the face of the global scramble for PPE, how will low and middle income countries source PPE required for treatment and for surgery? Like, for example, what are your countries doing to try to procure as much PPE as possible?
Right. So I don't know whether any of my colleagues will like to take it, but we started with wearing level 3 PPEs, those almost spacesuits kind of things. And over time, we have sort of gone down to level 2. And Luckily in India, PPEs, the N95 mask is now available through hospitals, pretty cheap. We wear a face shield. And we really managed to now get on with work with that. So we had problems with PPEs in the first month. Now those problems seem to be less. I think one of the things is the transmission during surgery. If you avoid going into the OR during the intubation, transmission from the patient to the surgeon is quite low. There is now data that it's not very high at all. So I think middle-level PPEs are usually enough, and we haven't seen too many surgeons in India getting infected. I'm aware that globally, of course, there have been surgeons who've got infected. So we've taken a middle path for PPEs.
Did anyone else want to comment on that?
Yeah, Kit, I just wanted to add also that I think one of the lessons coming out of this, COVID, is that there is, a critical need for global partnership. That no single country can respond to this exclusively and say by closing their borders and preventing people from leaving their homes or going across borders is going to shield them from the pandemic itself. So getting everybody around the table and consolidating our resources and reappropriating those resources to respond, to equip and capacitate the system to respond, I think is going to be critical. And that requires a public-private partnership. Like every actors, including those who are manufacturing these supplies. I understand the economic side of it, but people need to understand that there is a human side attached to this. That if you don't invest and you don't make these supplies affordable, eventually you will have no one purchasing those supplies. And I think this is a critical, it's not an emotional request, but I think it's just required of us and our shared humanity that we do not exploit the situation and maximize profit at the expense of people who cannot afford. So I think that's the one thing I'll add to this. And I just also wanted to put in a quick point, two quick points. One, that we're talking about all the things that are necessary to restart the surgery, but a critical first step in really getting that off the ground is really assessing the readiness and preparedness of the facility to actually restart the services. And I think that sometimes we take it for granted because we're already deeply entrenched into, we have to respond to the backlog, we have to start providing the services without really stepping back and saying, hey, here's our checklist. Have we met this? Have we met that? Do we have this? Do we have adequate blood supplies? Do we have, everything that is needed. So really ensuring that you do that and have that kind of findings or the information to inform what kind of intervention remains very critical. As far as obstetric care, one of the things that we did when I worked at Africare in Liberia to help the government, even though it wasn't a nationwide initiative, but we invested in what we refer to as maternal waiting homes. So the maternal waiting homes were really a lifesavers for expectant mothers because people were afraid to go to the health facilities. And so the maternal waiting homes were where expectant mothers came in. We hired a few certified midwives who were there to provide support. And for those who were ready, to give birth, we had them referred, or transported to the health facilities. Many of these maternal waiting homes were in close proximity to a health facility. So it was easy for them to go in there, do their deliveries, And if everything was okay, they just brought them back, and they, you know, so the maternal waiting homes also serve as postpartum ward for mothers. Those that had complications and needed C-section had to stay in there, you know, for a few hours or a day, but then also refer because people were so afraid of staying longer in the health facilities. Thank you.
Thank you so much for that. You raise a good point that we've discussed checklists and guidelines on patients, but we also need a checklist for the facility to make sure the facility is ready to reopen. You know, on the issue of the production of masks, I think another thing that will change post-COVID is previously our supply chains were really narrowing. For example, with one country, usually China, producing, you know, over 80% of the world's supply of certain types of PPE. And I think what we're going to see now is more countries trying to become at least partially self-sufficient in that PPE or other medical supplies. I mean, certainly the US has been running out of the testing kit supplies, like nasal swabs, you know, the viral medium. So I certainly could see countries like India and South Africa, which already have large manufacturing bases, pushing to start local manufacture of some of this PPE. Okay, do any of the panelists have any points they want to make that they feel they weren't able to make in their original presentations? Okay, I'm checking the questions to see if there are any other questions. Someone has asked if we could review a little bit more the categorization of surgeries into elective, semi-elective. Now, we understand it varies, you know, country by country. You know, Dr. Chu said in some contexts, every surgical patient in South Africa is you know, semi-emergent, that there is no such thing as, you know, an elective patient. But if some of our speakers could explore a little bit more how countries can think about, you know, elective versus semi-elective and how patients fall into those categories.
So, you know, if I can just, it's a difficult area, but so the way we have done it in one of the institutions I work is that, of course, it's easy to identify what is emergency. Somebody, it's a condition where the person would die if you don't offer surgical care within a few hours or so. And that's usually clear. It's also fairly clear to talk about a subgroup of patients who it's really elective. So you have cosmetic surgery, you have maybe bariatric procedures, etc. Now the ones in between is where the problem is. And one sort of parameter we used in the early days is that we said that what is the natural history of the disease and what is likely to happen if we don't operate. Is there a chance of mortality within the next few months? Are there alternative treatments? So we took that as a measure. Mortality, I mean, we are talking of non-cancer. Cancer, of course, is different. Chances of mortality in the next few months, in which case they are prioritized. Having said all this, I think when you start, you know, there is a mad scramble, and, you know, it also pressures from various departments. So, but this is some rough ways to look at it.
Great. Okay. Well, thank you so much. And with that, I would like to give the floor to Dr. Jeff Ibbotson to wrap up, but I would also like to thank all the panelists and everyone who helped us organize this webinar. And I hope that you'll join us next month when we have a webinar on leadership during the COVID pandemic.
Thank you, Kate, and thank you all of the speakers for quite an interesting discussion. As you guys have well noted, I think this is a new era of a world that we're living in. I think a lot of these issues are not going to go away, and we're going to have to be very dynamic and agile in planning and getting that care that we do need for our patients. And just the fact that so many people are suffering and dying and getting increasing disability because they can't get these surgeries is an enormous burden of illness that the globe is now facing. So thank you once again from the United Nations, UNITAR, and the Global Surgery Foundation. Thank you to Operation Smile and Stellenbosch and all the speakers. This has been wonderful. And we look forward to more sessions like this. And a special thank you to all the participants and those who participated in the question and answer. This has been a very good discussion. So from all of us at the UN, thank you very much and have a great day. Keep safe. And until next time, we'll just take care. Okay. Goodbye now.
Bye.